Thank you everyone for being here today. We actually have an international session lined up. In addition to our friends from Washington, we have some of our colleagues from Canada and some friends from Oregon joining in. These are interesting times, so your participation is truly appreciated. I'm Deepthi Mani. I'm a nocturnist at hospitalist at Valley Medical Center in Brenton, and I co-chair the ACP Washington Hospitalist Council. Just a few housekeeping items before we begin. We'll have a 40-minute session with our wonderful speaker, who I'll introduce in a minute. We'll have a 45-minute session, and then this will be followed by a 15-minute Q&A. The chat would be open during the session, and feel free to type in your questions in the chat, and we'll monitor that. The session is recorded, and the link would be shared with you after the session. So now it's my absolute pleasure to introduce you to our wonderful speaker, Dr. Divya Gollapudi. Dr. Gollapudi earned her MD from University of Missouri and completed her internal medicine residency from Oregon Health and Science University. She's currently an assistant professor of general internal medicine at University of Washington, and she's the director of the Perioperative Medicine Clinic at Harborview. She also co-chairs the ACP Hospitalist Council. Dr. Gollapudi, we are so grateful to have you here. Thank you so much for sharing your time and expertise. So over to you.
Hello, thank you everyone so much. So as Deepthi mentioned, my clinical practice is within hospital medicine at Harborview Medical Center, which is University of Washington Hospital, the County Hospital, and the Regional Trauma and Burn Center. Happy to hear that there are so many members from various regional ACP chapters. I'm really excited to present to you and happy to take any questions you might have. Can enter them while I'm talking and we'll try to get to them at the end. So I have no disclosures for this talk. There have been many exciting actually topics and new guidelines and recommendations that have come out in the last year or so. This talk will be a combination of kind of clinical background, new studies, but for the sake of time, I'm not going to critically review all the new studies, kind of like a journal club or from an evidence-based standpoint, but I'm going to review them and provide my perspective and kind of how it's changed my practice or how it's guided my practice. So today we'll review the new American College of Cardiology, American Heart Association guidelines for cardiac risk assessment prior to non-cardiac surgery. Think about updates in particularly ACE inhibitors and ARB medications, discuss GLP-1 agonist therapy, SGLT2 inhibitor therapy, and some new articles in perioperative brain health considerations. So likely the most important update within the last 6 months has been the release of the updated guidelines from the ACC-AHA for cardiac risk evaluation prior to non-cardiac surgery. This was really a long-awaited update because, as many of you know, the last version was published in 2014. And as guidelines are, it's a pretty long document, 90-some pages, and very comprehensive, actually. So it's not possible to kind of cover all the important aspects of the document today, but I'm going to hit on some salient points and try to apply it to really evaluation prior to urgent surgery. As you likely know, it's not kind of designed for particularly one clinical space or the other, but many of the recommendations, kind of timelines for optimization, tend to be prior to time-sensitive or elective surgeries, but I'll try to point out the things that would be useful and applicable to the inpatient setting. So since 2014, there have been some important additions to how we consider risk assessment preoperatively and some recommendations for postoperative monitoring. So some of the additions include recommendation for use of a standard questionnaire to assess functional capacity preoperatively, naming some conditions that increase cardiac risk perioperatively, but aren't really included in some of the available risk calculators or risk tools. Use of biomarkers to help with decision to testing preoperatively, postoperative testing, biomarker testing, timing of surgery after PCI or coronary revascularization and drug-eluting stent placement, some specific recommendations on pre-op coronary revascularization, and then several medication updates, which we will talk about today as well. So these slides, these algorithm slides are borrowed from the publicly available ACC AHA guidelines. They have several slide sets that are available. So sorry that the type is a little small, but um, the first, really, this is the first part of the cardiac risk algorithm. And really the first step is to identify active cardiac conditions. So the box that's listed as here with my laser pointer, does the patient have acute coronary syndrome, unstable arrhythmias, decompensated heart failure? And these are things you're obviously doing anyway or have captured on your history and physical exam when you're managing or admitting a patient to the hospital or seeing a patient in clinic. But if any of these issues are present, kind of parallel to your treatment, and triaging these issues, thinking about a multidisciplinary discussion with the surgical team, anesthetic team, and any specialists about timing of surgery, intraoperative management, or post-op monitoring. And then I think really one of the most important additions to the algorithm is the addition of some risk modifiers that are thought to contribute to cardiac risk significantly. And they were diagnoses we're already paying attention to and addressing, but kind of has now been codified in the guidelines. And these diagnoses are not typically available in our kind of classic risk calculator, something like the RCRI or Gupta or NSQIP. So I think for urgent surgeries, these are important to identify preoperatively to allow for potential management if needed, optimization, especially as an outpatient, planning for intraoperative monitoring, postoperative management. And some of these conditions may lead to more extensive risk counseling and really goals of care discussion, really getting into um, risks of surgery versus benefits and non-operative management. So we'll review these modifiers in the next few slides. So as you likely know, patients with severe valvular disease, such as severe aortic stenosis, severe mitral regurgitation, are felt to be at higher risk for cardiac complications perioperatively, for volume issues, arrhythmias, hemodynamic instability. And this has been listed again as a modifier in the updated guidelines. So guidelines recommend an echocardiogram if known valve disease, and no echo within 12 months. I think some people might prefer 6 months for monitoring of especially known moderate or moderate to severe valve disease, or symptoms or murmur, especially in the setting of a low functional status. And then lesion-specific management, cardiology assistance as needed. And then aortic stenosis being probably the most common valvulopathy identified preoperatively. The guidelines will make based on kind of pre-existing valve guidelines or ACCHA valvular heart disease guidelines, consider that if severe asymptomatic and an EF of over 50% may be reasonable to proceed with surgery. Under 50% EF or symptomatic, consider valve treatment if the timeline allows, which may not be possible prior to urgent surgery. And they make sure to mention that surgery appears to be safe and okay, non-cardiac surgery early after valve intervention, and they kind of call early within 30 days. But if valvular heart disease has been identified, then a team-based approach involving cardiologists, anesthesia, surgeons is recommended to optimize their perioperative care. Other conditions that increase cardiac risks include severe pulmonary hypertension, high-risk congenital heart disease, recent stroke, cardiac devices, and frailty. So severe pulmonary hypertension is associated with a high risk of perioperative morbidity and mortality as patients are at higher risk for respiratory failure and RV failure. So this is a diagnosis that may require surveillance with an echocardiogram or more invasive testing coordination with the anesthesiologist, really, so they can assemble an appropriate team for the day of OR. So an anesthesiologist who understand and can perform intraoperative monitoring as needed, and maybe someone you monitor in the ICU postoperatively, regardless of the surgery. Recent ischemic stroke, the guidelines have now added to consider delaying time-sensitive or elective surgeries for 3 months after an ischemic stroke, because proceeding with non-cardiac surgery within 3 months is associated, the data suggests that it's associated with a high risk of cardiac morbidity and mortality. So this is obviously something that is kind of addressed if you're seeing a patient who can safely delay their surgery for that amount of time. but may not be possible in the urgent or inpatient setting. Just important to know that a recent stroke does contribute to a patient's risk. Cardiac devices, pretty standard care and device interrogation in your institution, whoever's responsible for that, coordination with the anesthesia team. And then, frailty is a diagnosis or a condition perioperatively that is a very important topic in and of itself, and a lot of discussions over the last few years on the identification, management, prehabilitation of frailty perioperatively. But now it's been added as a risk modifier because the diagnosis of frailty, or if someone screens positive for frailty using several risk tools, does increase risk of cardiac complications. So for urgent surgeries, the identification of significant frailty plays, I think, into the bigger picture, thinking about goals of care, surgery benefits versus non-op care, discharge setting, monitoring for delirium postoperatively. Attention should be paid to patients who have had a recent PCI. And really the guidelines have updated the timeline for elective non-cardiac surgery. That's my last bullet point on the slide. Elective non-cardiac surgery after drug-eluting stent placement, and actually are now saying 6 months if the stent was placed for chronic coronary disease, and maybe up to 1 year after acute coronary syndrome. I can't say that I've recommended a year quite yet. Of course, these guidelines were just proposed a few months ago, but it's definitely a change from the recent, or I think shortly after 2014, there were some stent recommendations published. So the year is a bit longer than the last recommendations. But acutely, for someone who had a drug-eluting stent put in within 3 months, our management from a hospital's perspective should be to discuss antiplatelet therapy with either their cardiologist or in-house cardiologist, if presuming surgery requires an interruption of their dual antiplatelet therapy. If the drug-eluting stent was put in over 3 months ago, it's likely okay per the guidelines to interrupt DAPT and the patient to proceed with urgent surgery, though it might depend on the complexity of their stenting and their risk of in-stent thrombosis based on the number of stents or the anatomy they have. And I'm sorry, this slide actually has a lot, but this is the next part of the algorithm. But the most important, I think, next step prior to an urgent or inpatient setting is the assessment of functional status. So I consider, as many of you might, I consider functional status to be one of the primary pieces of information I use to often determine further testing and to kind of provide risk counseling or kind of triage a patient's risk based on their other clinical history. Functional status is considered a marker for tolerance of physiologic stress and recovery after surgery. We've historically, and the guidelines recommend using 4 METs as a threshold for functional status. But it seems, based on a study a few years ago called the METS trial, that actually using a standardized questionnaire, in the METS trial, they used a questionnaire called the Duke Activity Status Index. Using that standardized questionnaire to assess function was a better predictor of perioperative cardiac complications than just kind of subjective assessment, which is how far can you walk, how many blocks, or kind of variability in how we ask as different providers. And they propose a threshold based on the odds ratio of 34, as that was associated with an odds ratio of 1.97 for 30-day mortality, or MI. So in the urgent setting, I think understanding the function helps triage symptoms and exam findings for their much needed surgery urgently. So if they have a murmur, for example, if someone has a murmur, no prior echocardiogram, and they have robust function, you may feel comfortable, and the team may feel comfortable proceeding with surgery if needed, if unable to obtain an echocardiogram preoperatively, versus someone who can't function, can't walk, might be frail, and you don't have any prior echocardiogram data, you might delay their surgery for further testing. This is the Duke Activity Status Index. It actually, I think, originated from the cardiac literature, maybe with cardiac rehabilitation and kind of keeping tabs on how a patient is recovering. So as you can see, this reference is from 1989. So it's not a new score, but newly being applied as far as I know from the last few years after the METS trial to the perioperative assessment. So it basically suggests a wide variety of activities that require physical stamina versus just walking. So we traditionally have been asking how far can you go and stairs. And the more activities a patient can do, the higher the score. So as you can see, that's kind of the threshold of 34, which is really based on what the authors of that study felt like was an acceptable odds ratio for, or odds or likelihood of cardiac complications. So it's not a set in stone. If you can't do 34 on the DASI, you shouldn't have surgery, etc. It's just that was the risk associated with 34. But as you can see, it actually requires quite a bit. It includes a lot of activities, and I would say many of my patients, at least in clinic, who have especially really significant spine disease, who get a lot of who get the bigger elective spine surgeries, can't do many of these things that would add up to 34 points. For completeness, I added the last part of the ACCHA guidelines, but this part I think is more applicable to elective and time-sensitive surgeries, where there's time to optimize chronic conditions or time to perform pre-op testing. But as a significant update, the ACCHA guidelines are now recommending the consideration of a pre-op BNP assessment, which is in the yellow. It's a 2A recommendation, as well as circled here at the bottom, a post-op troponin surveillance. For those who practice in Canada or follow the Canadian guidelines, pre-op guidelines, wherever you are, the Canadian Cardiovascular Society has included these recommendations in their guidelines. I think it was published in 2017. So now the American guidelines have included it as well, which is a pretty big change. So BNP can be measured as either BNP or NT-proBNP, as you know, is elevated in response to various stimuli, stretching or affecting the myocardium, including inflammation, hypoxia, ischemia. And really several studies have shown that an elevated pre-op BNP or NT-proBNP is associated with post-op cardiac risk. And so given this data, it's been kind of previously recommended in high-risk patients by the Canadian guidelines and European guidelines that pre-op BNP be used as part of the risk assessment and maybe as a way to avoid more invasive cardiac testing preoperatively while trying to risk stratify. It's likely low utility as a risk stratification tool prior to urgent surgery. But I wanted to mention it as an addition to the guidelines. At this time, prior to elective surgeries or planned surgeries where patients I'm seeing as an outpatient, I'm still primarily using the BNP as a more diagnostic tool. So let's say there's someone slated for a high-risk surgery with a very low functional status, something like a big spinal fusion, and they have some vague dyspnea on exertion, maybe related to deconditioning and pain. I may start my evaluation with a BNP, understanding that if it's elevated, then I might do an echocardiogram. Same way if they have like some lower extremity edema, which many patients do, especially if they're less active. I might start with the BNP if my concern for underlying structural heart disease actually isn't very high, but I'm not quite sure, and I want to make sure as best as possible before they get a big surgery. The guidelines recommend kind of the upper limit of normal as a cutoff, so it's BNP is 92 and NT-BNP is 300. Which there's no kind of, I think, data on the exact cutoffs. We do know the higher the BNP, maybe that relates as in this graphic to a higher risk. So that would be more of a subjective provider to provider decision on what threshold to use or what threshold to use as a cutoff for high risk or to decide on further studies. But I'm generally going right to the cardiac test if I'm very concerned for structural heart disease otherwise, and using BNP, I guess, if I'm less concerned, but kind of as a ruling out test. That's my practice, at least for right now. The guidelines do recommend or do state it may be reasonable to measure troponin at 24, 48 hours after surgery to identify myocardial injury. And this is to diagnose a condition that is known in the perioperative literature as MINS, myocardial injury after non-cardiac surgery, which is a condition really characterized are defined by an elevated cardiac troponin after, again, a non-cardiac surgery. It's presumed to be related to ischemic mechanisms and includes both type 1 etiology, so acute block rupture, and demand etiology, so type 2 and STEMI. The incidence is felt to be about 20%, some variability in the literature, but high if we're doing screening on all, post-op patients. 20% may have an elevated troponin, and it is associated with increased long-term mortality, as you can see on this graphic, 1-year mortality, 30-day mortality. So a important clinical diagnosis associated with short-term and long-term mortality. So the guidelines, and this is also in the Canadian guidelines as well from several years ago, we're recommending that patients who are at high risk or had an elevated BNP preoperatively, that they have troponin surveillance postoperatively. And really, if a patient has elevated troponin felt to be related to demand, I think the first question is it acute plaque rupture, and treat that as you would normally treat that. If demand ischemia in this with no symptoms, that can lead to either enhanced monitoring in the hospital, telemetry, etc., med management, management of risk factors, early cardiology consult, referral to cardiology as an outpatient, maybe a stress test as an outpatient, though they already had kind of a physiologic stress test. So the definitive treatment of MINS is still evolving, but they're encouraging us to diagnose it to then potentially manage risk factors to help potentially reduce their patients' mortality in the future. So as a summary, kind of applying the this algorithm, the ACCHA guidelines to urgent or inpatient settings. I think one is assess and confirm the surgical urgency, identify and any active or acute cardiac conditions, treat as normal, and kind of have the multidisciplinary team discussion. The presence of risk modifiers may guide your treatment, may guide intraoperative management or post-op care. I think I try to have a good big focus on team-based care, especially in the perioperative period where there's lots of different important players. So discussing any of those high-risk conditions with the anesthesia team, however that workflow or communication stream is in your institution. Then thinking about surgical risk, benefit, delay, goals of care, if really high risk modifiers or acute cardiac conditions, and then managing medications, which we'll talk about. As an addition to cardiac risk assessment and an update in the nature of updates, I wanted to discuss this interesting paper study called Hip Attack. Hip Attack, the hip fracture accelerated surgical treatment and care track, I think, was a randomized control trial, I think published in like 2020, looking at accelerated surgery versus standard care in hip fracture and reducing death or major complications. The original study included about 3,000 patients. And then this study published just in December was a sub-study looking at patients who had a troponin elevation or troponin measured at hospital presentation. So it ended up including about 1,300 patients. And the study wanted to know if accelerated surgery would be okay and safe in those patients with myocardial injury versus standard care, as standard care may include delaying those patients with myocardial injury for further optimization and testing, and just to kind of wait to make sure it's okay to proceed. The primary outcome was all-cause mortality. In the original study, there was not a difference in 90-day mortality rates in accelerated groups versus the standard care groups in the bigger cohort of 3,000 patients. So 23% of patients had an elevated troponin on presentation. The median time to surgery in the accelerated care group was 6 hours. The standard care group was 29 hours. And really interesting, the accelerated care group had a 10% 90-day mortality rate, and the standard care group had a 22% mortality rate. It has a ratio of 0.43. So accelerated surgery was associated with a significantly reduced 90-day mortality rate. And then the risk of, I didn't list it here, but the risk of major complications was also reduced, 14 versus 30%. So really interesting. The authors speculated or postulate that hip fracture is associated with high physiologic stress. It's pro-inflammatory, it's hypercoagulable, it's causes this huge stress state, and that exacerbates myocardial injury. And then you have myocardial injury, which then leads to poor cardiac reserve. Um, you have treatment of NSTEMI with beta blockers that may cause hypotension, aspirin that may contribute to bleeding, and all of this can be solved by potentially going to surgery and relieving the physiologic burden of the fracture. So, this data really challenges the traditional approach potentially of delaying surgery, at least for a few hours to, you know, stabilize or fully evaluate and get their cardiac history and cardiac status. So it might be a paradigm shift in those patients with hip fractures and STEMI. Really interesting, I thought. So there have been several publications in the last 1 to 2 years that have looked at the management of renin-angiotensin inhibitors. So in my slides, I'll refer to these as RASI, and I'm referring to ACE inhibitors and ARBs. So there was a POISE-3 trial, Stop It Not SPACE trial, and then the guidelines, and then just more recently, a systematic review. So there have been a lot of discussion about ACEs and ARBs, I feel like, over the last few years. Current practice can vary institution to institution and maybe by providers, but it usually includes typically stopping ACE inhibitors and ARBs preoperatively, either on the morning of surgery or the night before surgery. And that's because continuation has been associated with higher rates of intraoperative hypotension. I believe that's all kind of non-randomized data. And then if you ask anesthesiologists or perioperative providers, and you might also think that you would provide robust anecdotal data that, yes, likely continuing these meds, you've seen patients have significant hypotension when they get these meds. And then there was interesting data several years ago now that looked at patients who I think interrupted ACE inhibitor therapy perioperatively and then did not resume it within 2 weeks postoperatively for whatever reason. Actually, that was associated with an increased 30-day mortality. And so we're taking these highly beneficial medications either for for heart failure or for diabetes and not resuming them postoperatively. So is the interruption worth the risk of not continuing this highly beneficial chronic therapy? Um, so the POISE-3 trial was a multi-center international randomized trial, included 75,000 patients, adult or over 45 years old, getting non-cardiac surgery. They all had to have some kind of cardiac disease or cardiac risk factors, and they all had chronic hypertension on antihypertensive therapy. And the study question or the comparisons were hypotension avoidance group versus a hypertension avoidance group or strategy on complications. And they had a composite of vascular death, non-fatal MI, stroke, and cardiac arrest at 30 days. So in the hypotension avoidance group, they held ACE inhibitors and ARBs for the day of surgery and the first 2 days post-op. And then they gave other blood pressure meds through an algorithm, starting at, I think, post-op only if the blood pressure was above 130. And then they had a target map intraoperatively of 80. So I think this group is most similar to at least my clinical practice when I'm following post-op surgical patients, kind of a careful reinitiation of meds. And then the hypertension avoidance group really continued most medications and had a lower target map of 60. So the primary outcome, as I said, was a composite of major vascular complications, death, non-fatal MI, stroke, cardiac arrest. And the results were essentially that there were similar incidents of vascular complications in both groups. The adherence to the sign strategies, I think, for holding meds was suboptimal. But the intraoperative goals, I think, were met. But the authors kind of said that there were similar results across adherence levels. There was more hypotension in the hypertension avoidance group. So the group that had their meds resumed, there was more hypertension in that group. And then the results were consistent in patients who used more than one medicine for blood pressure. So it didn't seem like it correlated with the severity of hypertension. So this, again, kind of, I think, is similar to the kind of anecdotal data that we have and maybe some of the non-randomized data in terms of increasing hypotension potentially perioperatively. SPACE trial was a randomized control trial published last year that looked at the question of, does discontinuing these medicines, it's double negative, discontinuing these medicines reduce the risk of myocardial injury? I guess presuming that continuing them maybe contributes to hypotension, maybe contributes to myocardial injury. It's the opposite way of thinking about that. Multi-center randomized control trial in the UK. Older patients, 60 years and older, undergoing elective, I should say, non-cardiac surgery. All these are non-cardiac. And their primary outcome was myocardial injury, and they defined that by high sensitivity troponin. Medications were stopped 2 to 3 days prior to surgery based on the medicine and the half-life. So not necessarily stopping just the 1 or 2 doses or 1 dose ahead of time. So the top row, so you have primary outcome, adverse events, and then the group that stopped had a 48% elevated troponin, and the group that continued their ACEs and ARBs had a 41%. So essentially similar effect on myocardial injury. The odds ratio is 0.77, but not statistically significant. And then under the adverse events, patients who stopped their meds had more hypertension, maybe not surprising, but hypotension in this study was similar. So essentially the take home was discontinuing these meds does not seem to affect myocardial injury and maybe actually could increase risk of hypertension. They felt like there was a trend toward more myocardial injury in the group that stopped, maybe related to the hypertension. And then for the last of the randomized control trial, Stop or Not was published again last year. This was a multi-center randomized trial in, I think, up to 40 some hospitals in France. And they were, again, looking at, is it better to continue ACEs and ARBs or better to discontinue? And they also stopped 2 days ahead of time. They included adult patients, I think over the age of 18, having surgery and on these medicines at the time of surgery. They looked at composite of all-cause mortality and major complications. There were a lot of complications they looked at: cardiac, respiratory, sepsis, kidney injury, a lot of different things. Again, similar rates of the primary outcome. Continuing kind of had similar rate of mortality and major complications as discontinuing. The episodes of intraoperative hypotension occurred more frequently in the groups that continued. They required more vasopressors, but the time was real short. Like it was just a few minutes difference in the amount of hypotension more frequently, but then the time was like 6 minutes or something in hypotension events. So I think this kind of shows that both strategies seem safe, though discontinuation again seems to reduce intraoperative hypotension. So I feel like we started back at the beginning. Same with a very more recently published meta-analysis looking at 59,000 patients over 16 studies. Essentially, if you hold their ACEs and ARBs, they have less intraoperative hypotension. Interestingly, they found an association with AKI as well, which hasn't come up in these recent papers. And I have to say, I didn't get to look at exactly which studies reduced AKI, but that's something that's on my list of things to do. But they found an association with reduced AKI, which I haven't seen in any of the big studies myself. But there's no significant difference in perioperative mortality or MACE. So after 2 years of new studies, a lot of new studies actually, we're back where we started, I feel like. And that's where the guidelines kind of ended up that were published before the meta-analysis, but after these randomized trials, although Stop or Not might not have been published, I'm not sure. Essentially, consider and probably stop ACE inhibitors and ARBs 24 hours prior to surgery to limit intraoperative hypotension, which is the only consistent outcome. But maybe in patients with heart failure, continuation is reasonable because it's a very beneficial medication in those patients. They may tolerate a lower blood pressure, and we don't want it to kind of fall off their medication list. And no guideline rec on Entresto. We're holding that for now. Very interesting study. This is kind of a feasibility study for a bigger trial called Improve, I think. And this was just basically a study the Improve trial, which is the bigger one, is going to look at personalized intraoperative blood pressure management versus standard care, which is kind of MAP of over 65. And so they want to compare nighttime. They want to basically make their intraoperative blood pressure goal the patient's nighttime MAP. So this was just kind of a prelim for a bigger study that's upcoming, but I thought it was really cool idea that each patient has their own goal blood pressure based on nighttime monitoring. And they felt like that was a feasible thing to do, to monitor a patient's nighttime blood pressure to reach and to make a new intraoperative goal and to maintain the intraoperative blood pressure over that nighttime blood pressure. So we could be seeing some changes in intraoperative blood pressure management. So SGLT2 inhibitor use, there have been some recent updates. So as you know, SGLT2 inhibitors used in diabetes and increasingly in heart failure. They decrease glucose by inhibiting glucose reabsorption from the proximal renal tubule, means contributing to glycosuria, and then increases glucagon, which then kind of increases plasma ketones and free fatty acid breakdown into plasma ketones. So kind of mimics a state of carbohydrate starvation. So with all of that, there is a risk of what's called euglycemic DKA in stress or fasting states. So acute illness and then pre-op fasting or a pre-op low carb diet. The true kind of incidence or likelihood of euglycemic decay is relatively unclear. It seems like it's really based on case reports. There was a systematic review of like 52 case reports that suggested that patients had euglycemic decay if they continued their meds within 2 days of surgery, but not if they held it for 3 days prior to surgery. Another data set suggested a 1% incidence in emergence procedures and really, really low likelihood in elective cases. As far as I know, no data set looking at patients with heart failure on these meds for heart failure alone. I think all of them have included diabetes. But with all of this, with the case reports, the FDA recommendation 2020 was to stop these medicines 3 to 4 days ahead of time. I say 3 days because canagliflozin, dapagliflozin, and empagliflozin are 3 days ahead of time, and then orforgliflozin is 4 days prior. But say in my practice, the first 2 are most common. I don't know if empagliflozin is locally available. So just 2 months ago, there was a retrospective cohort study looking to answer the question of, is this therapy associated with post-op DKA? The patients underwent surgery 2016 to 2022. It was 34,000 patients enrolled in these insurance plans, and they were looking at rates of DKA within 14 days post-op, defined by diagnosis codes. And the kicker there is they could only use DKA and acidosis diagnosis codes because there's no diagnosis code for euglycemic DKA or SGLT2 inhibitor DKA, or yeah. And 2,600 patients were using SGLT2 inhibitors in this cohort. Most were not, but similar rates of diagnosis of DKA or acidosis in this kind of study. So no difference. But the ACCHA guidelines is recommending holding 3 to 4 days based on the case reports in the FDA kind of label and recommendation. So 3 to 4 days prior to surgery. So my clinical practice is to follow the guidelines. But if you're managing a patient who's newly fasting or unexpectedly fasting, who is taking SGLT2 inhibitor therapy within the last 3 days, considering monitoring for euglycemic decay, even by just keeping track of the anion gap, or checking ketones, because it obviously is a diagnosis that may not come to light quickly because their blood sugars are more likely to be normal or within range. The argument for continuing in general is that it's very beneficial therapy in heart failure, but we don't have any data in patients with heart failure alone. It's hard to know for patients with DK on SGLT2 inhibitor therapy how much of their decay is related to diabetes alone versus the medication effect. Updates in GLP-1 agonists, a medication that has been being discussed for the last few months on management. So these medications, as you know, used in diabetes and weight loss. They're semaglutide, Ozempic, or Wegovy, dulaglutide, Trulicity. They work obviously by decreasing gastric motility and gastric emptying, but there have been reports and concerns about the risk of regurgitation and gastric and aspiration during general anesthesia. And a lot of that data is out of the GI literature and prepping for and during endoscopy have noticed or reported increased gastric residuals in those patients. But the association between GLP-1 therapy and post-op pneumonia is really unclear. Some studies have reported an increased risk and some studies haven't shown a difference. So last year in 2024, there were a lot of different conflicting recommendations and kind of discussions on how to manage these medications, especially from obviously an anesthetic point of view, and if patients will arrive to surgery with a full stomach, even though they've been fasting because of these medications. So in the last 6 months, American associations or professional organizations got together and released one clinical practice guidance doc. And then just recently, British professional associations gathered and released another document. The American guidelines says to consider holding these medications in high-risk patients. These are patients who might have symptoms of reduced gastric emptying or delayed gastric emptying and on high doses, but likely to continue in all other patients. And then a liquid diet, consider a liquid diet in 24 hours prior to surgery in those patients who are high risk. And then thinking about point of care gastric ultrasound, which may or may not be available depending on anesthesia ability. But thinking about that as a way to screen for retained gastric contents on the day of surgery versus canceling their procedure, perhaps if you're worried about that based on symptoms or a patient reporting that they didn't follow fasting guidelines entirely correctly or took their medication when they weren't supposed to. The British guidelines are kind of more hands-off. I think it seems like the guidelines I read as worried about the risks of cessation, which includes hyperglycemia perioperatively if you stop the GLP-1, and the long half-life. So holding one dose prior to surgery may not reduce the risk completely and then will be kind of too reassured. So they are seeming to recommend continuing it in the majority of patients, but talking about the risks and making an individualized decision with the patient. Really just says usual fasting guidelines. They don't mention anything about liquid diet. And then their guidelines also say don't just use the symptoms to determine gastric content. Either look with the point of care ultrasound, gastric ultrasound, but don't, like, for example, I read it as don't cancel a patient's surgery because they're like feeling nauseous or something. So a bit more general, and maybe just because there's not really great data to make these strong recommendations. Just last month, a retrospective cohort trial, again, based on database and diagnosis claims of post-op pneumonia and respiratory failure in patients on GLP-1 agonist therapy. And as is the trend with all these studies I've presented today, no difference. Very small number of patients use this therapy. And there's no difference in post-op aspiration or acute respiratory failure based on this. This was published obviously very recently after all these guidelines and um, or practice doc or clinical guidance documents, not guidelines, but consensus statements were published. But so your practice may depend on your institution. There might already be kind of an anesthesia potentially or preference. But or at least I'm generally continuing therapy weekly just because that's what our institution is doing. But I am holding if there are any upper GI symptoms. So I just saw a patient yesterday who was like, I'm nauseous all the time. She's on Ozempic. I'm like, okay, well, it's probably because you're Ozempic and let's hold it before your big spine surgery. Our institution is doing a clear liquid diet for 24 hours pre-op in all patients taking these medications for planned surgeries. It is not yet a protocol inpatient. But there is a risk for volume depletion. Just recently, there was a patient that this happened to. She was traveling to Seattle for a big surgery, didn't drink a lot of water, was in a hotel, didn't have access, I guess, to a water fountain, and came in hypotensive from volume depletion. So there are risks of this management as well. And then if patients are on insulin for diabetes, which they might be, you'll have to adjust the insulin dosing for their clear liquid diet day as well. So a lot to think about for this kind of route. And then lastly, just 2 minutes, talking about some perioperative brain health updates. In just a few months ago, the ASA published what they call a practice advisory for perioperative care of older patients scheduled for inpatient surgery. Focuses on 5 questions, and they kind of supported or data supported answers, few of which related to outpatient or hospital kind of medical evaluation, and the others were more anesthesia care or intraoperative care. Kind of the takeaways are assessing the importance, kind of stressing the importance of assessing delirium risk. So thinking about pre-op screening for cognitive impairment, frailty, as we discussed, post-op delirium prevention, which you're already likely doing, geriatrics consult if available. They did not report us. They felt like there was no superiority in the data with general versus neuroaxial anesthesia with reducing post-op delirium, which I thought was really interesting. They in the data, and you might know this if you practice, just from your practice or just because you know it, that Precedex or dexmedetomidine um, seemed to be in a meta-analysis helpful in reducing delirium. Of course, that's an ICU or PACU level care because of the hemodynamic effects of Precedex. And then don't have time to review this data in detail, but there was a meta-analysis out of, I think, Korean Journal of Anesthesiology. I didn't put my reference there. Korean Journal of Anesthesiology that showed that NSAIDs in that meta-analysis was associated with the reduced delirium risk. And it was felt, and also reduced pain and reduced opiate use. So either the delirium risk was reduced by kind of reducing or like a neuroinflammatory reduction, reduce pain or reduce opiate use. There's often some concerns with using NSAIDs, especially in orthopedic patients because of bone healing and bleeding. And then older patients might have medical contraindications to NSAIDs. But something to think about maybe for a very focused group or a small group of patients that could tolerate NSAIDs and who are high risk for delirium. The Precision trial was published in December of 2024 that looked at the incidence of post-op stroke after elective non-cardiac surgery. This was at 2 centers in China. And they were looking specifically at covert stroke, so asymptomatic stroke, and the association with delirium and post-op neurologic kind of outcomes. So they included several patients. I think I don't know why I wrote 34,000. Sorry, it's like 900 patients. That's a big trial if it's 34,000. 900 patients who were older, who were admitted for surgery, and they all got brain MRIs within 7 days. And they looked at how many strokes they basically found. They assessed pre and post-op neuro cognitive function with the mini mental status exam, MoCA, and other kind of functional testing or other cognitive testing by phone post-operatively. So they initially excluded patients getting neurosurgery. but they were doing their study during the COVID pandemic, 2018, I think 2022. So there's really slow recruitment. So they ended up including a lot of neurosurgery patients because those were the only surgeries, I guess, at these centers that were moving forward because they were felt to be kind of urgent and required. So ultimately, the majority of patients ended up having neurosurgeries, but still included some other kinds of surgeries. And what they found was that 12% of patients had a covert periop stroke. None had what they called an overt stroke. And patients who had covert stroke were at actually significantly higher risk of having delirium postoperatively. It reported an odds ratio of or twice as likely, and then neurocognitive decline at 1 year as well. 70 Most patients who had a stroke actually had embolic strokes, interestingly enough. So it's something to consider, and the authors kind of postulate or suggest that we should consider a stroke as an etiology for delirium postoperatively. We don't have a better way to look other than MRI. There's no equivalent cardiac biomarker. And potentially there's going to be an embolic etiology. So kind of doing the workup for embolic stroke is part of that as well. But felt like the take home was covert strokes are common and meaningful. And then this is just a visual representation of the association between covert stroke and delirium. So my clinical practice, probably not different from yours, but standard delirium precautions and care postoperatively. At least in our clinic, preoperatively prior to planned surgeries, we're doing quite a bit of counseling on risks of perioperative delirium and cognitive dysfunction, brain fog after anesthesia. This is especially so in patients with known cognitive impairment, or we screen for cognitive impairment or advanced age. There's some nice patient handouts on the ASA, I think like quality. They have a brain health initiative website that the QR code is there. It's like really patient friendly docs, like how to prepare for surgery. And it's things like bring your glasses and have your phone with you and, get all your meds together. It's very common sense, but it's things that often are not discussed in kind of the planning of surgery, especially for older folks. Covert stroke is associated with delirium. So I wish I didn't read this trial because I keep this diagnosis in my head for patients with delirium, but I hesitate to put all of them through MRIs, but something to keep in mind. And then, the role of NSAIDs in post-op pain management. So we talked about a lot today. This is my take-home points. Risk modifiers that contribute to cardiac risk are important to consider in your pre-op cardiac risk assessment per the ACCHA guidelines. MINS is an important clinical consideration, so we may be doing more post-op troponin surveillance moving forward. We're holding ACE. I think the cumulative data says continuing ACE inhibitors and ARBs is associated with intraoperative hypotension, which can have unmeasured harm, right? More fluid, more blood, poor organ perfusion, though not associated with long-term harm in the data. Consider holding on the day of surgery, but promptly resume postoperatively when safe. We're doing a liquid diet for GLP-1 agonist therapy as an outpatient, but consider holding that therapy the week before surgery for patients with delayed gastric emptying, SGLT2 inhibitors, or 3 days prior to surgery hold. And then thinking about neurocognitive risk counseling in older patients or those with cognitive impairment like delirium, post-op, or longer-term cog impairment, and potentially stroke in that workup. Thank you very much. If you have any questions, happy to take them. I think we have 2 minutes. And then if you could, fill out an evaluation for it's my division evaluation form. It'll help me in general. There's the QR code or the URL. It's just kind of a form, easy to fill out form. If you have the time, I would really appreciate that. Okay. Are there any questions I can answer? No questions?
Can I ask you something, Divya?
Yeah.
Okay. So regarding men's,
Yeah.
who do you actually check with troponin levels for surgery? I mean, if I were to look at high-risk patients, the geriatric patients who undergo hip fracture surgeries, I mean, they are older, they have diabetes, they have high blood pressure, they're technically high risk. I mean,
Yeah.
but unless they have symptoms, do you typically test
So
them?
right now in my current personal practice, I'm not checking post-op troponins in asymptomatic patients.
Okay.
Um, it's been discussed for a long time because it's been part of the Canadian pre-op guidelines for quite a few years. And I believe their guidelines are to check it in. One of their definitions of high risk for planned surgeries, at least, was an elevated BNP preoperatively. So, like, check the BNP pre-op. If it's high, those are the patients maybe you'll want to screen for post-op MI potentially. It's not the same for urgent surgeries, obviously,
Sure.
but I think there's kind of work to be done as a system, right? Like when we're checking these troponins post-operatively and thinking about a treatment plan for those patients. Do you leave do you leave an elevated troponin as is and just risk counsel? Do you start on new meds? Do you call cardiology? I think that part isn't definitive. So I have not been checking myself on these patients.
Got it. There's one question on DOAC on the
Yeah.
chat. There's so regarding DOAC, like what dose is used in patients?
Oh,
Mhm.
um, I can't say that I know the answer for specific dosing in gastric bypass, um, for post-op prophylaxis. Part of the reason is because here we're not doing, I'm not caring for gastric bypass patients at this institution, but I don't know if there's a different dosing in them. I'm sorry.
Okay, I think that's all the questions we have. Thank you so much for such a
Yeah,
comprehensive presentation, Divya. I mean, you've covered lots of ground, and there's plenty of reading material for us to review, given
yeah,
the stop and act trial. Sorry, the hip attack trial and stop and
yeah,
choice
yeah.
free and whatnot. So it was awesome. And thank you
Thanks.
everyone for spending your time with us.
Thanks.